Rachel with the recording. And we'll go to the next slide.
Right. So our first official question to Dr. Campbell and the group: how do we best diagnose VTE during pregnancy?
And Dr. Johnson got us kicked off with that. The next slide. And this is perfect lead in. So 80% of patients with a lower extremity VTE will have unilateral swelling and pain. The calf difference is usually over 2 centimeters. And ultrasound is the best diagnostic tool. It's the least invasive and it's very diagnostic. I think there are times when it will be inconclusive and you're just convinced the patient has a clot. And I think in those cases, you can consider empiric low molecular weight heparin while you're planning to repeat an ultrasound of the lower extremity up to a week later. Some will do an MR venography, but really in pregnancy, we just repeat the ultrasound of the lower extremity. If you have concerns about a pulmonary embolus, this has always been, a topic of debate everywhere I've been. And do you order the VQ scan or do you order CT angiography, the spiral CT? And the bottom line from all of the stuff that's been published looking at accuracy of diagnosis, both are extremely accurate in making the diagnosis of PE. So then you say, well, which is the safest for pregnancy? Well, if you look at the radiation exposure for the fetus, the spiral CT has the lowest radiation for the fetus. And it's low radiation for mom, but it's more radiation than the VQ scan for mom. And for the VQ, it's just the opposite. But again, both have extremely low amounts of radiation exposure for both mom and fetus and are very safe. I think one of the keys is just your institution, which is felt in your institution to be the best for your radiologist. And if you take VQ scans and you take 10 radiologists and give them the same VQ scan to read, they're all going to read it differently. Where the spiral CT is pretty spot on between radiologists. So that's something that's important to know. The VQ scan is not as black and white as the spiral CT. And spiral CT is not perfect, but it is a much more black and white type of tool to diagnose pulmonary embolism. So I think at most institutions, CT angiography is the one that goes to. Donna, is that what you guys do at MUSC? And Dr. Gailey?
Absolutely. That is what we do. And I will tell you, the one thing that physicians, including myself, have been guilty of is with a VQ scan, it's low, medium, or high probability. And, I don't think I've ever seen a negative one. So, low probability, there's still a 10 to 15% chance that there's a PE. And I always hated that. I hated a low probability in somebody that was symptoms. So I was so happy for that chest CT.
The one thing that we're seeing now is more and more data looking at a cumulative effect of radiation exposure in breast cancer and other later onset in life malignancies. So we're going to see more and more information on that. There's a group in, I want to say, it's not Yale, but it's in the Northeast where they really, really have pushed the VQ. And at their institution, they have made it a positive or a negative VQ scan. And that's changed the utilization of it there. The other thing that they do is start out with a chest x-ray. And if there's any chest x-ray abnormalities, then they go to the CT rather than the VQ scan, because we know that pneumonias or atelectasis or any kind of mass in the chest decreases the efficiency of a VQ scan. So you're right. And the other thing is, you're only as good as your institution and your availability of nuclear studies at night, for instance. Most places don't have that availability 24/7. So anyway, I agree with you wholeheartedly. Comments, questions, folks? If not, Michelle, you can go to the next slide.
So what serum testing for women with a history of VTE not tested before? So what would you want to run?
So this is really where you were coming from, Donna, that I didn't touch on. Next slide. And I like to just mention this because of the importance of what's the accuracy of testing for these in pregnancy. The mutations are accurate whether you're on anticoagulants or pregnant or not. So the factor V laden and the prothrombin gene mutations are accurate no matter what. So those two are easy. The antiphospholipid antibodies certainly can be affected by pregnancy, but they're still reasonable to get. The antithrombin and protein S and C are all three affected by pregnancy. And by anticoagulation. If you have a patient with a PE, you've put them on the medicines. Should you do those tests? The accuracy of those tests are just not going to be very good. But if you've got the patient that Donna's talking about in the office, you certainly can do the test. If they're normal, they're normal. You feel better about it. But remember, and I'm probably going to mess this up. I think is it protein C that is elevated by pregnancy and contraceptives, and protein S that's the opposite? I may be getting that wrong.
I know for a fact that protein S is a decrease.
Okay.
Okay.
So protein C is the opposite of that. They're both affected by pregnancy. So you just can't hang your hat on those levels, but can you do them? You certainly can do them. I don't know how you manage those, Donna, but I just like for people to know that those things can be affected by pregnancy and by anticoagulants.
So I told this nurse today, I said, now I know you're going to look at your labs. And I said, let me just warn you, there's some that's abnormal in pregnancy. It's just how abnormal they are.
Exactly.
And the protein, prothrombin, I said, that is the one I'm worried about the most. And I said, antithrombin 3, I mean, I think I've seen one of those or maybe two of those in my career. They are rare. But the rest of them, I've seen lots of them.
I agree.
But the other thing that I really, really, really want to emphasize is that for recurrent miscarriages, the appropriate test is your antiphospholipid antibodies, lupus anticoagulant, beta-2 glycoprotein, and anticardiolipin, IgG and IgM, okay? Your inherited thrombophilias in the background population is up to 20% depending on the race and ethnicity. So please just don't order these tests willy-nilly for like recurrent miscarriages. Order both inherited and acquired thrombophilias for blood clots, but only antiphospholipid antibody for recurrent miscarriages or an IUFD.
That is a great point. We used to do the whole panel for that, and that's not appropriate testing.
And they have thrown MTHFR out the window.
Gone. It's gone.
Don't check it anymore.
Next slide there, Michelle.
So we have a new VTE in pregnancy. How are you going to manage? And again, please put notes. I'm trying to engage you guys in the chat box. So use your chat box as we're going through these.
And I get this call often, does this patient, because we're managing these patients differently than we used to. Next slide. So, you know, we used to put all these patients in the hospital right away, but a little bit less consistent across the board now. And if they've got a PE, we admit them if their saturations are labile or they have severe shortness of breath or severe chest pain because we're worried about them. But if a patient has mild shortness of breath, their O2 sats are normal, you don't see a lower extremity DVT, or if you do, it's small, these patients are perfectly safe to be started on low molecular weight heparin and sent home. So we're doing that more. I will still say that the majority of these patients are admitted to the hospital at least for a 24-hour observation period. With a DVT, I think outpatient therapy is, again, reasonable. If I have a patient that has severe swelling and severe pain, we will often admit them. And one of the things that we will still do on occasion is use IV heparin. Now, it's harder, I think, to get them anticoagulated with IV heparin just because of the many vagaries of dosing. But IV heparin has an anti-inflammatory benefit as well, particularly when you have these patients with a severe erythema and pain in their lower extremities. But we don't do it for everybody. And just because they're pregnant doesn't mean you have to put them in the hospital. So that's my opinion. I'd love to hear what others think. And if you feel like you need to put these patients in the hospital, that's fine. It's certainly within the realm of appropriate care, but I don't believe that it has to be done in every patient. Any other comments?
All right. So what do you do if you have a patient who is allergic to heparin?
And what I mean with this is allergic to the unfractionated heparin, which is the heparin of old that we used to use all the time. Next slide. I think it's important to try to define what that allergic reaction was. Is it erythema? Is it itching? Is it just the red spot associated with it? And if that's the case, a lot of these patients can use the fractionated or low molecular weight heparin and do very well. If I have a patient with a true allergy to heparin, to unfractionated as well as low molecular weight heparin, then it's out of my realm of comfort. I'll call hematology oncology, because there are other medicines that can be used, but I'm not nearly as familiar with those, and I get their input. Thrombocytopenia with unfractionated heparin is pretty uncommon. I mean, it happens less than 0.1%. And generally, you see thrombocytopenia with long-term unfractionated heparin. You can see it with Lovenox, but it's much less common. So if somebody has had that reaction with unfractionated heparin, you can generally use Lovenox safely. The only thing I always mention is we don't like to use the oral agents like Eliquis and others, because they do cross the placenta and they do cross into breast milk. Warfarin is certainly safe to use if you need to, particularly in that postpartum period when they are breastfeeding, but it's just harder, in my mind, to keep therapeutic, but that's just the way I manage patients. And I'm happy to field questions. Or Donna, do you have any other comments about? And I didn't even mention the bone density issues, because that's again something you see with long-term use of these agents. Any questions or comments?
I totally agree with you, Barry. The question I have for you is, if you put somebody on heparin, sub-Q heparin, do you follow up a platelet count, and if so, when?
I typically don't, Donna. I think people that have talked about that say in 8 weeks, because it's rare to see any effect on the platelet count before 8 weeks. And generally they talk about it 3 to 4 months later. But I typically do not follow the platelet count. I just do my routine labs during pregnancy and postpartum.
So that's what I do, but I was just wondering if other people do that too.
Yeah. I think a lot of folks are very cautious about it, and I'm fine with that, but I think in reality, the need is low. Rachel, you can go on to the next slide.
So how do you decide the dose? Prophylaxis versus immediate versus therapeutic?
And this is right off of your question or your case presentation, Donna. You can go to the next slide, and the next 3 or 4 slides are right out of the bulletin. And I tell everybody, y'all just look at this, have this bulletin available. And it helps guide you. Go to the next slide, and the middle one, the low risk thrombophilia without a previous VTE. This is the one that Donna was talking about. And that's surveillance without anticoagulation therapy. And if you take that low risk thrombophilia with a family history of VTE, then it goes up to the prophylaxis versus just surveillance. And then in the postpartum state, to do the prophylactic or intermediate dose. Go to that next. Well, actually, you can either. This is fine. It doesn't matter. But if you look at the top box here, this is the part that I think makes it a little bit harder. When you have a clinical scenario and the suggestion is do any of the 3 you want to. Do prophylaxis, do an intermediate weight-based dose, or do fully therapeutic. So by how on earth do you decide then? Well, that's when you talk to the patient and say you got everything from the Fiat 500 to the Mercedes Benz over here. The fully anticoagulated is going to give you the lowest risk of clot, but there are risks associated with that. The prophylactic dose is the most tolerable, right? I mean, I would not mind taking 1 shot a day with a much lower dose and have a much lower risk profile. And there are some that, and this is particularly my healthcare providers that I take care of, they say, let's go in between. Let me go kind of pretty good, but not quite as risky. And they'll go with the intermediate dose. And I use that dosing protocol from the Royal College that I posted up on our website from 2 times ago, using the weight-based intermediate dosing schedule. So I think you just have to explain it to the patient, help them understand that there's no fully protective dose, but there are benefits and risk, and you just have to kind of pick your poison, so to speak. And that's the way I let the patient participate in that. And then I have some that don't want to take anything, and that's fine. I mean, they have to make their informed decision as you go through this. You can go to the next slide so that they can see this while we're talking through this.
I had a quick question for you, Barry.
Please.
For the patients who have two low-risk thrombophilias, are they then automatically considered to be in a high-risk category by them
Yeah.
having those two? Does
Yes.
it matter which two or two?
So if they have two of the low risk thrombophilias, that does put them into the category of using some type of prophylaxis, whether it be prophylaxis with intermediate or just a low dose. If they have a low risk thrombophilia plus a high risk, then they're automatically
Right.
high risk, and then those mostly go with the therapeutic dose
Okay.
but yeah, you see this top box group here. And even when they have two low risk thrombophilias present, you really can do any of the dosing schedules that you want, even prophylaxis. But what I preach to my patients is prophylactic dose once a day is better than nothing. And they always want to do low dose aspirin. Low dose aspirin does not protect against clots in these patients that we're talking about. That is not the purpose for aspirin in this group of patients. But that's great.
So, Barry, can I just offer a different perspective?
Sure.
So I'm a cynic, and I'll admit that up front. And so I believe in therapeutic or low dose. It is a rare patient that I put on an intermediate dose. Okay. If they don't want full anticoagulation and I feel they need it, they got a clot or they've got, a high risk thrombophilia and they've had one or two clots, I would put those on full anticoagulation. But if they won't take it, then I offer them intermediate. But to me, I have never gone and dug for the evidence on intermediate, but I think that's even more of an expert opinion than the prophylactic dose and the therapeutic dose. And my young colleagues chastise me all the time because I didn't use an intermediate dose. And so I just tell them, once I see them and I get them started, y'all just follow my plan and say it's Dr. Johnson's.
You're right on target. I mean, a lot of people do that, and the data is slim. It's just more pharmacologic, and the studies that are out there are more pharmacologic studies, not based on outcomes. Frankly, it really is not.
And the other thing I will tell you, most of the time we do 40 milligrams for prophylactic dose. But I think that if you got somebody with a BMI of 50, you need to do a higher prophylactic. I do a higher prophylactic for a BMI of 40. Now, again, there's no evidence for that. But if she has a PE and dies, I'll feel a little bit better.
Yeah, I would encourage everybody to go back and print off that that chart from the January 16th talk that we did that has the weight adjusted that the cardiothoracic surgeons and the Royal College has posted. It's very simple, and it's very useful, I think, when you're looking at weight-based regimens. And I that's just going to be a problem as we see our population get bigger. I mean, people are not getting smaller, and it's going to be a bigger and bigger issue. So I think it's something that you need to at least take into consideration. I agree with you.
Now, I will tell you, I have talked with our bariatric surgeon, who I have a tremendous amount of respect for. He just does, he increases them, when they're above 40, but he says, I do that, but I don't know the correct dose to use.
Yeah, nobody does.
No.
And go ahead, Michelle.
Do you monitor levels of low molecular weight heparin in pregnancy?
And this is one of those things that I get a lot, and the answer is no. And I really don't monitor it often, even therapeutically used, unless they've had a PE in the pregnancy, and I'm really worried about them being therapeutic. And if you do monitor the anti-factor 10A, you check 4 to 6 hours after the injection, and your level should be 0.6 to 1. So they have to know when they had their last injection when they come into the office to get that drawn. That's really the only point I wanted to make. And one of my partners feels very different than this. And let me tell you, there is no data to support following levels in anything other than therapeutic Lovenox use anytime, but in pregnancy too. So
the only one I get really anal about is the therapeutic in somebody I'm worried about because they got a current heavy load PE,
right,
or a mitral valve replacement in the first trimester. Those two I'm very OCD about, but the rest of them I'm not as worried about. And I'm like you, I might check them once, 3 times in a pregnancy.
right.
And I just check them to see if I need to go up on the dose.
It does. That's right. That's exactly right. With these large ladies, it can be difficult for sure.
And for the next one, I will just tell you, it doesn't matter that you use 10,000 units TID. I have never seen an APTT therapeutic on 10,000 3 times a day. So I just change them and pray.
Yeah, because it doesn't do it. It doesn't. No. You're right. Next question. I think this is about.
So how do you start to manage your medications surrounding delivery?
So I don't think that there's an answer for this one up here, and I just tell you what I do. Well, go to the next slide. No, this is different than the last question that I think I had. I think there's another question in there too. This is just, yeah, this is it. This is the real question. I wanted to see what everybody thought in the audience. Do you change to unfractionated heparin at 36 to 37 weeks, or do you leave them on low molecular weight heparin? I would love to poll everybody for you to tell me what you do, or even if you don't manage this, tell me what you see with your practitioners. Because you may remember a while back when unfractionated heparin was shortage, and then we just had to leave people on Lovenox, right? And you just stopped at 12 to 24 hours before delivery. I have totally stopped switching people over. I leave them on low molecular weight heparin now, and I just try to stop it before delivery. That it's always a gamble, people say. Cynthia, I see you had unmuted yourself. What do you do there?
Yeah, I was just going to say that I recommend that they change it over to heparin just because that was what I thought we were supposed to do. But most of my patients don't do it, mainly out of, I guess, uncompliance, or they just don't like the heparin. They feel like they can take the Lovenox a little bit more easily. And so they tend to just not want to change over. So.
I'm curious, Donna, do y'all, I saw somebody else chatted in the chat box that they do switch over at 36 to 37 weeks. Donna, do y'all still do that?
So it's very interesting. If that we got somebody that's got a C-section around 38 weeks, we just stop it beforehand. Okay. We do recommend changing over around 36 to 37 weeks. Still, Especially if they want an epidural. But sometimes when I tell them to switch over, I'm counseling. I said, well, doctor, I hadn't taken that other medicine. Why do I need to take a new medicine?
Yeah, that's exactly right. I'm not taking it anyway. Does it really matter? Dr. Gailey, what do y'all do in the upstate? Do y'all switch over or do you leave them on Lovenox? Are you with me? I don't have everybody pulled up. Or anybody from Dr. Gailey's group or Eric?
Hey, this is Savannah. Actually, I'm Michelucci. I'm one of the chief residents. I'm
Hey.
here with Dr. Gailey.
Yeah. What do you do?
We're both trying to figure out the whole computer situation.
That's okay.
We try to switch them over to heparin. I feel like what usually happens with the patients though is that they come in for another reason and then need to be delivered early. So then they never make that formal transition. But whenever I first started, I felt like we were trying to switch them over to heparin, and I still feel like that's true.
Okay. I think that may be what most people do, but we don't do that here in the Midlands. And then this is the last question, and we're out of time, but I'll go ahead and put the answer up there that at least my approach, what you do is general population after a C-section, particularly those that were not planned C-sections, those that were just done with failed labor. Next slide. And the key is pneumatic compression devices before, after, and until the patient's ambulating. Ambulate them as early as you can. And I know I'm a little bit different than a lot of people around here, but I still like that scoring system from the Royal College. And I use their risk factor assessment. And I counsel on Lovenox use a lot after C-sections, particularly when they're still in the hospital. And I may send them home on nothing or send them home on something for 10 days or so. But even though the risk is low, the risk is real. And with the size of our patients, and then the most common risk factor that leads for us to do something is obesity. And we just see so much obesity with preeclampsia and diabetes and all that. We use a lot of Lovenox post C-sections in the hospital. So that's just my opinion. And I'm glad for Donna to weigh in on that too. But that's something that I think we're going to see more and more as we move forward.
I totally agree. I absolutely agree.
Well, I feel like we've gone over almost every session this time. This has been one of those areas that I like because it's so controversial and there's so many ways to skin a cat, and they can all be reasonable. And hopefully this has given you a little bit of guidance, and at least if not cleared things up, it's made you think more about what you do or what you don't do. Ask the question, be proactive, encourage patients that need to be on anticoagulation to be on it. And they have to make the ultimate decision. What we have to do is counsel them and document that we counseled them and ask the questions. You don't get credit if you don't write it down. So make sure that you do that. And we'll move on. These are our upcoming topics. Dr. Johnson is going to take the reins and talk. We're going to get into patients with prior COVID infection, which is becoming a more and more commonly encountered issue with particularly long COVID syndrome. Domestic violence, which is something that we frequently bury our heads in the sand over, and we need to be more advocates for that patient population. Obesity and pregnancy, we've talked about a bunch, and we just are seeing more and more. And then late term steroids. So any comments or questions from anybody before we